So hopefully at the end of the talk, we'll be able to sort this out. Next, please. So what I'm going to be doing is my talk is based on a series of questions that I think with time we all ask ourselves, either when we're dealing with the patient or when we're thinking about it. So what I'm going to do is I'm going to ask certain questions and present the data that hopefully respond to those questions. So the first question is, what are the facts about penicillin allergy? Next. Penicillin is the most common drug allergy identified in the MR. I think we all probably realize that. 10% of the US population, it's actually 33 million persons, have a documented penicillin allergy. And I will come back to that. True IgE-mediated, that is immediate type allergies that cause anaphylaxis, are actually very uncommon. Next, please. Oh, I'm sorry, let me get the last point. The last point, this is important, and this will be reemphasized. More than 95% of the patients labeled as penicillin allergic tolerate this class of drugs. So we'll be reiterating this time and time again. That's a number you really want to keep into your memory bank. Next, please. So why are 95% of patients non-type 1 penicillin tolerant? Because most commonly reported penicillin hypersensitivity reaction is really a delayed benign rash, probably a type 4 T-cell mediated. Now, when a person is exposed to the same drug later on, they may or may not have that kind of a rash. The IgE-mediated penicillin allergies do wane over time. 80% of patients become tolerant after 10 years. And I'll come back to that and I'll show you data to show you how that data was acquired. So that's another point to continue to remember. Many patients were really never allergic. They had drug intolerance, other causes, maybe had a little nausea, maybe a little headache. And they were younger, they might have had a rash secondary to a viral illness, and the doctor gave them an antibiotic. Next, please. So what are the consequences of being labeled as having penicillin allergy? Next. The consequences are the use of alternative antibiotics really can result in several things. They're very obvious. More treatment failures, suboptimal treatment. For example, when people have MSSA bacteremia or serious infections, and they're treated with vancomycin, there's a 17% failure rate and mortality with vancomycin. So vancomycin is not to be used with patients who have MSSA bacteremia. So that would be suboptimal treatment. Adverse effects, such as vancomycin, our friend again, gives you nephrotoxicity. Probably 15 to 20% of the people that get vancomycin for greater than 3 days will have nephrotoxicity. And when you add Zosyn, Piptazo on that allergic reaction and nephrotoxicity increases. Also, you can have C. difficile infections. And also, when you use other antibiotics like clindamycin, the fluoroquinolones, certainly we can increase the risk of C. difficile infections. And there's also data to show that when you use those antibiotics, you can actually increase MRSA and vancomycin-resistant enterococcal nosocomial infections. They contribute to the development of antimicrobial resistance, and obviously that's what we're looking for, right, to prevent because of our ubiquitous antimicrobial stewardship programs throughout our whole MD stewardship programs throughout the country. And this was the prime reason why antimicrobial stewardships were set up both by the CDC and the WHO. And increased healthcare costs. And there's an interesting study that was done that showed the cost saving per patient with a penicillin allergy was anywhere from around $1,100 to $4,200. So that's really interesting. We don't think about costs other than, do you use a different drug that may be a little more costly. They looked at all aspects, so that's a big figure. Next, please. Next case. 43-year-old man with diabetes hospitalized with a closed tibial fracture. 3 years ago, he was being treated for a foot infection with piptazo or franzosin. He developed a very itchy rash. The anesthesiologist calls to ask advice about surgical antibody prophylaxis prior to the operative fixation. Next, please. So what does this case introduce us to? It introduces to the second consequence of penicillin allergy and different antibiotic use, and that is surgical site infections. I don't think it's something we really think about, but surgical site infections are so important to the hospital and to our patients. So the study was retrospective, and they wanted to assess the SSI risk among surgical patients reporting a penicillin allergy. So they didn't do skin tests, it's just the history. Again, over 8,000 patients, 9,000 procedures. Their penicillin allergy was 11%, and throughout America it's around 10, so that's about right. They had a normal baseline SSI of 2 to 7%. 2 to 5 is kind of common. Next, please. Okay. And the types of surgeries were the ones that we're all used to: the orthopedic, total hip, total knee, elective hysterectomies, elective colons, and CABGs. And what they found out was that patients with the reported penicillin allergy had a 50% increased odds of an SSI attributable to receipt of a second-line perioperative antibiotic. Instead of cefazolin, they received Vanco, Clinda, Gent, metronidazole, or fluoroquinolones. So that's something we really want to keep in mind, and particularly with the orthopedic surgeons. So the burden is on the surgeons to get a good history, and if we're seeing them preoperative, for us to get a good history, and for anesthesia as well, because going back to the 95% patients that don't have penicillin allergy, when you look at the number of patients that are getting vancomycin in your institution because of penicillin allergy, that can be reduced significantly, probably by 95%. Next, please. So what is the cross-reactivity between all of the beta-lactam antibiotics? Penicillin versus the cephalosporins. So been numerous studies that have been done, and among patients with an immediate type IgE penicillin allergy confirmed by skin testing. So the penicillin skin testing is really a surrogate marker for IgE allergy. 97% of the patients who have confirmed skin testing, positive IgE, so that's a type 1 immediate reaction, are tolerant to cephalosporins. 99% are tolerant to carbapenems, and 100% tolerate aztreonam. Those are numbers you want to think about and remember. So we can use someone who has a penicillin allergy, and I'll come back to categorizing them, but keep that in mind that 97% can have cephalosporin, and 99% can have carbapenem, and 100% can have aztreonam. Next, please. So what is the reason for the cross-reactivity? And I'm not trying to make biochemists out of us. I just want to give you a little bit of a concept. So the beta-lactam ring is circled under the penicillin. You can see that. And if you go down, the beta-lactam ring is in the monobactams, aztreonam. It's in all of the cephalosporins, the cephalopenes, the ceftriaxone, cephalexin, and the carbapenems. The only difference are the side chains. And the difference between cross-reactivity is not based on the fact that all of these have the beta-lactam ring. It's the fact that they have different R1 and R2 side chains. So I don't want everybody running out and listing the 25 cephalosporins and comparing their R1 and R2 side chains to see if they'll cross-react with penicillin. That's not the point. But that's just for a concept to remember. The nice thing about the penicillins are that, go ahead, the next slide, please. Next slide, please. Okay, so let's go back to the cross-reactivity again. Let's look at what is the cross-reactivity per generation, because there is a difference, a generation of the cephalosporins. If we look at the rate of cross-reactivity for first generation cephalosporins, it's less than 5%, and the first generation would be, the main one would be cefazolin. Second generation, it decreases to around 2 to 5%. And the second generation, just off the cuff, cefaclor is one, cefoxitin, which is used by OBGYN and sometimes prophylactically for colon surgeries, and ceftaroline. The third generation, which is what we use most of the time, ceftriaxone, cefepime, there's less than 1% cross-reactivity. Again, that's based on the side chains. I do want to emphasize with cefazolin, cefazolin doesn't have an R1, R2 groups, and it doesn't share that with any other of the beta-lactams. Therefore, cefazolin can be used very safely in the majority of patients pre-op for getting pre-op prophylactic antibiotics, and that should be emphasized to the anesthesiologist and to the surgeons. With aztreonam, the only cross-reactivity is ceftazidime, and I just say that for the sake of completion. We rarely use ceftazidime anymore because cefepime has replaced it. But again, if the history was 10 years ago, they may have gotten ceftazidime. Next, please. So, is a person who is penicillin skin test positive forever positive, and how long is forever? So, the penicillin skin testing is you can think of it as a surrogate marker for IgE allergy, type 1 allergy, anaphylactic allergy. And that's really what we're trying to sort out, to find out if a person or persons have a type 1 allergy, allergic reaction, anaphylactic type 1, IgE mediated. If they don't, then we can more than likely move on. So there have been numerous studies looking at skin test positivity and looking at the loss of skin test positivity with time. One study doing it for 1 year, checked the patients with skin test positive at point time 0 and checked them 1 year later, and 10 to 20% of those patients became skin test positive. That means they lost their IgE allergy. There were some studies for 5 years. One study looked at just penicillin allergic patients only, and they saw the skin test positivity decrease by 37%. Another study looked at patients who were penicillin and cephalosporin allergic, both of those together, and they had a loss of skin test positivity at 68%. And there was a study that looked at patients for 10 or more years. It was a study that included between 450 patients. It was a really unique study. They looked at all these patients at baseline, and every year they did skin testing. Over the 400 and some were skin test positive, and they followed them annually over 10 years or more and doing skin tests, and found out that after 10 or more years, 80% of them lost their skin test positivity and therefore lost their IgA-mediated allergic reaction to penicillin. So the actual number was 78%, but I put 80% because that's easier for us to remember. Next, please. And this is a graph, just a visual, showing the percentage of patients on the left positive skin test at time 0 and at 1 year, and then going down to greater than 10 years. And the numbers become small, but this is the standard reference that people use to talk about skin negativity after 10 years. Next, please. So what type of reactions occur with penicillin or beta-lactam antibiotics? So the reactions are all immune mediated, and Gell Coombs were the first group team to discuss the type of drug reactions, whether they're antibiotic or regular drug reactions, and they put them into 4 categories, type 1 through type 4, and I'm going to go through each one. They This was in 1963, so obviously things have changed, and they have been updated regularly as recently as last year in terms of explanations for each reaction and particularly the T cells, because as you know from what we have with the cytokine storm with uh, with COVID, the T cells and the cytokine storm, the cytokine response is really, really important. And so this has really been updated. But Gell Coombs is what everybody uses. The allergists, the immunologists all use Gell Coombs type 1 through 4 reaction. So I'm going through each one quickly and I'll relate to why it's important for our patients. So type 1 reaction is IgE mediated. It can present with any of the following or combination: pruritus, urticaria, swollen tongue, dyspnea, diffuse erythema, chest tightness, periorbital or perioral edema, or anaphylaxis, which include urticaria, angioedema. Some have nausea and vomiting, hypotension, and shock rarely. Really, statistically, anaphylaxis is really very uncommon when it comes to a reaction to antibiotics. But look at these symptoms and signs that people have, because we're going to talk about how important they are when we're doing a history taking so we can categorize people and decide how we want to approach them with treatment. Next, please. So these are just a photo showing an IgE mediated reaction, and we've all seen it. Obviously, you walk in, it's diffuse erythematous. It may be pruritic, doesn't blanch on pressure. Most of them are raised, but you can tell that particularly on the second one and the third one that has localized on the third photograph. But these are IgE mediated, and again, these people have pruritus as the key component to this, because when we talk about the type 4 reactions, some of them may also look like that, but they're not pruritic. Next, please. Sorry about that. So the type 2 reaction is IgG and IgM mediated. And what happens is the IgG and IgM react against the host cell's surface antigen and produce a cytotoxic response. Now, what does that mean clinically? Well, they can attack the RBC, the platelets, and the neutrophils, and also components of the kidney. So what does this result in? One, you can have, if it attacks the RBCs, you can have drug-induced hemolytic anemia. If it attacks the platelets, you can have thrombocytopenia. If it attacks the neutrophils, you can have granulocytopenia. In my experience, granulocytopenia is more common than hemolytic anemia or thrombocytopenia. Those are really rare. Neutropenia, granulocytopenia, you see occasionally, and this is the main reason why we do CBCs weekly for patients that are receiving antibiotics greater than 2 weeks. Osteos, endocarditis, 4 to 6 weeks, septic arthritis, because by usually, in my experience, around the third week is when they may start dropping, and you can watch them. They just may go from 4,800 down to 3,200 to kind of stay there. Usually, they do not plummet dramatically and quickly, but that's really important. That's why you have to do serial CBCs on patients who are getting antibiotics longer than 2 weeks. And you can have proteinuria and hematuria if it attacks the interstitium of the kidneys and gets you nephritis. We want to go back to that last slide. I'm sorry. Next one. Going back one more. There we go. I avoided. Go back to the type 1, please, Jackie. There we go. Thank you. Can you slide that up? I didn't. Can you see the bottom? On the bottom, it should say time. Is that visible? I don't see that, because this is the key. The time of the development of the urticaria, the rash, etc., is the key element for type 1 reaction. And it occurs minutes to usually less than an hour. Some people extend it to 2 hours. This is the key to separating type 1 reaction from other reactions, which I'll emphasize a little bit later. Next, please. Next. So on the bottom, that should be on the first one, the typical onset for a type 2 reaction is not minutes to hours. It's greater than 72 hours up to 2 weeks. Next, please. The third type, and I'm not going to spend time in, is immune complex. Clinically, you could have arthritis and arthralgia and interstitial nephritis with kidneys. Again, the onset is greater than 72 hours. Again, not like IgE mediated where it's minutes to hours. Next, please. Type 4 reaction is the most common reaction. When people have a rash from a drug that's not IgE mediated, it is a type 4, and it involves the T cells. And this is termed delayed reactions as opposed to type 1, which is an immediate type reaction. The major manifestation is our friend, the morbilliform rash, which goes back to the history of that was taken. Case number 1, patient had a rash. It was ill-defined. You can have rare types of type 4 reactions, AGEP, DRESS, Stevens-Johnson syndrome, and toxic epidermal necrolysis. These are uncommon reactions, but they can be very, very severe and some life-threatening. Next, please. So this is the benign T-cell mediated reaction. So this would be the reaction that the patient tells us about. I had this rash several years ago, and this is what they would be showing us. And you can tell, again, you walk in the room, it's a drug reaction. That you can tell clinically the difference between, it could be raised, the difference between this and the IgE mediated is the fact that it is periodic and the time element from the start of the rash. The T-cell mediated are going to be greater than a day and maybe several days. Next, please. The most serious T-cell mediated type 4 is called SCAR, severe cutaneous adverse reactions. And here are some photos so you'll remember these. In the oral mucosa, when people get Stevens-Johnson, they can have mucosal abnormalities. You can have desquamation in the center, desquamation of the palms, the hands, and of the skin and the feet. This is also typical for streptococcal toxic shock syndrome once they recover. And you can see the oral mucosal involvement. And again, just kind of keep these pictures in mind when you're talking to someone, because we want to make sure that they have not had this kind of a severe type 4 reaction for which we couldn't give antibiotics. So it's just not something to forget, because they could forget about it. And they're probably, Stevens-Johnson is I don't know how many have seen Stevens-Johnson, it can be life-threatening, a very, very severe reaction to any drug, and particularly antimicrobials. Next, please. So what do we need to do to clinically evaluate a patient with reported penicillin allergy? The next few slides are the most important, so this is what you want to focus in on. And at the end, I will give a summary of all the important points. So the history is the most important to separate IgE-mediated from type 4. So the first question is, what exactly were the symptoms? Were they a rash? Was it a rash, Was it raised? Was it itchy? Periodic? Were there spots? What about swelling of the mouth, eyes, lips, tongue, angioedema? How about blisters or ulcers of the lips, the mouth, the eyes, the vagina, peeling the skin, the slides that I just showed you? Could that be Stevens-Johnson or toxic epidermal necrolysis? Absolutely. Were there any respiratory components or hemodynamic to suggest anaphylaxis? Or did your doctor say, your kidneys really didn't work very well, or you had abnormalities in your liver to suggest hepatitis? A very, very important question. Question number 2, next slide, please. What was the timing of the reaction after taking penicillin? Minutes to hours, or was it days or weeks later? If it's minutes or less than an hour or 2, then you really have to assume it was an IgE reaction. If it's several hours, 18 hours, 24 hours, days later, then it would be a type 4 reaction. Next, did it begin after the first dose or after multiple doses? Because if it happened after multiple doses, then it obviously was not a type 1 reaction. The rapid onset of symptoms, that is within minutes to hours, usually less than an hour, after the first dose of an antibiotic, distinguishes immediate from delayed reactions, and that's what the history is about. That's what we're trying to separate. Next one, please. How long ago did the reaction occur? This question is most important for immediate reactions because patients may lose their sensitivity with time. If it occurs very quickly, minutes to hours, it's a type 1. If it's beyond that, it's going to be a type, mostly a type 4. Going back again and reiterating, 80% of patients with immediate penicillin allergy confirmed by skin testing become skin test negative after 10 years, and they lose their penicillin allergy. The IgE is gone, their anaphylactic is gone, and they need to remove the label that's in the EHR. And that is important for the clinicians as well as the pharmacists to do that. Next, please. Question 4 and question 5. Question 4, how was the reaction treated and by whom? Were you in the doctor's office, they gave you epinephrine, anaphylaxis, or it was an immediate type reaction? Did it occur in the doctor's office shortly after getting your antibiotic? Or did you go to the ED immediately? Did they send you there, or did you go there 2 days later? Did you self-medicate? Did it resolve on its own without treatment? And this is why when we're getting the COVID vaccine, they're keeping us for 15 minutes to make sure we don't have a type 1 reaction. Question, the last question, number 5. This is standard. We ask people, has the patient tolerated similar beta-lactam antibiotics, such as cephalosporins, since the initial reaction? So they said, I had this bad rash 10 years ago, and well, have they given anything like cephalexin? Oh, yeah, I did get that. How'd you do? I had no problem. How about amoxicillin, augmentin? Yeah, I did take that, and I had no problem. So again, these are the 5 questions that you want to ask that will give you the diagnosis of IgE versus non-IgE mediated reaction. Next, please. Can you do a risk stratification for patients with a penicillin allergy history? And what do you do with the stratification information? This is important. So what we do is, after taking a history, that history allows us to stratify patients into 3 risk categories for penicillin allergy: a low risk penicillin allergy, a moderate risk, or a high risk. So what do we do with those categories? We'll take a history, categorize them, and then we'll have an action plan. So if you have a penicillin with a low risk category, they have to have the following history. They might have an isolated non-allergic reaction like GI symptoms, headaches, etc., that were not related. Or say, as our first case, they have a family history of penicillin allergy. Penicillin allergy history or penicillin allergy is not genetic. So anybody who says, my parents had it, or my brothers and sisters have it, no, there's no genetic component to that, and they should not be labeled as penicillin allergic, and the patient should be told that, explain that to them. Pruritus without a rash. Remember, for IG, it's rash with pruritus. And again, a remote greater than 10 years of an unknown reaction or reaction that was not specific, without features of an IgE-mediated reaction. Most patients that have a documented penicillin allergy by skin testing have a low risk histories with a low risk, have low risk categories, and they can be low risk histories, and they can be categorized as low risk. So the action, I don't know if people can see this or not, I can't see it on my screen. The low risk is to do an amoxicillin challenge, which I will talk about in just a minute. Next, please. Next, penicillin group is the moderate risk. So for moderate risk, we go by the history and they say, yes, I had urticaria or other pruritic rash or had other reactions that have the features of an IgE, but I didn't have anaphylaxis. They're in the moderate risk category. So what do you do with those people? You do penicillin skin testing, which I'll cover in just a minute, followed by the amoxicillin challenge under observation if the skin test is negative. You can also, if you're dubious about it, consider allergy or immunology referral for their evaluation. When you do penicillin skin testing, a negative skin test has a predictive value of greater than 95%. And if after the negative test you perform an amoxicillin challenge, then it reaches 100%. And next, please. So what is a high-risk category defined by the history? The history for a high-risk category would include anaphylactic symptoms, a positive skin test previously, recurrent reactions. I get an antibiotic and I have this reaction. Maybe multiple different ones that are really not well defined. You have to think that might be a high-risk patient. And reactions to multiple beta-lactam antibodies. Gee, I got amoxicillin, had a reaction, which you can understand. I had cephalexin. So that's when you've had multiple beta-lactam antibodies, you really have to look at the possibility that, and I would put them in a high-risk category. What is your action plan for someone with high risk for penicillin allergy? First thing you do is refer them to allergy and immunology referral. You do not want to do a penicillin skin test on them. Now, if someone's in the hospital and they require desensitization for the antibiotic that you want to give, the beta-lactam, I'm not going to go through the protocol of the indications. You can discuss that with the pharmacist. But I will tell you, and you probably already know this, if you desensitize someone, they lose that desensitization very quickly, generally within 24 hours. So if you stop the medicine and you need to restart it 2-3 days later, they need desensitization. Just remember that. Next, please. So how do we manage penicillin allergic patients? Putting all of this together, what's the bottom line here? Next, please. We can manage penicillin allergy patients by doing the following. Number one, we can do skin testing to establish IgE. Again, remember that's a surrogate marker for IgE-mediated penicillin allergy. Initially, several years ago, the only people that really did skin testing were the allergist and the immunologist, and maybe that's your experience to date. But actually, physicians, nurses, PAs, and pharmacists can all do skin testing. It can be done safely as an outpatient, and it can be done safely as an inpatient when you are educated, certified, for lack of a better, and you understand having all of the anaphylactic medications available. But this is really standard procedure in many, many hospitals throughout the country. And you can do, so that skin testing, again, is really going to be rare, not rare, but uncommon that you really need to do that if you get a very, very good history from the patient. You don't need to do that, generally speaking, with the exceptions that I showed you in the moderate and high-risk groups, not the high-risk, but the moderate penicillin allergy groups. You can do an amoxicillin challenge, and it was to be the most common thing we would do. Next, please. Oh, before I forget, if you do penicillin skin testing, there are contraindications. You don't need to commit them to memory, but just remember that everybody can't get skin tests. If they've had a blistery rash, which we've shown previously on the slides, if they have hemolytic anemia, nephritis, hepatitis, fevers, or joint pains, the skin testing would be contraindicated, and again, you need to refer them to the allergist immunologist. Next, please. So what is the amoxicillin drug challenge? There's really a lot of data on the use of amoxicillin for drug challenge in patients with low risk category for penicillin allergy. particularly in children, but also in adults. The drug challenges, they used to be by allergists to exclude the presence of the IgE-mediated allergies, and they've been doing that for decades. So this is not a new phenomenon. For us, the oral amoxicillin challenge to check out beta-lactam Abs, beta-lactam allergies would be the following. You could do one of two protocols. The first one would be, first thing I would do is I would discuss it with the patient and say, look, I know you have this penicillin allergy, and you don't want to be labeled it for multiple reasons that you discussed with them. How about if we check you out by giving you the antibiotic to see if you are truly penicillin allergic? And most people say to that, and there's obvious advantages for the patient, and you can point those out to the patient. So the challenge would be the following. Either with 250 or 500 milligrams of amoxicillin, usually 500 is what the hospital has in the hospital pharmacy. Give it to them orally with 1 hour of close observation to make sure they do develop IgE-mediated response. And then, if they don't, then you can give them whatever IV beta-lactam you want to give. Or you can do starting with the 10th of the dose, 25 milligram oral challenge, wait 30 minutes, no adverse reaction, give them 50 milligrams of amoxicillin, wait 30 minutes, no allergic reaction. You can go to the dose of 250 or 500 and observe over 30 minutes. And these can be also done with children with lower dosages, and there will be protocols for that. If, again, after those 3 doses, they don't have an allergic reaction, then you can give them the IV antibiotic safely. In patients who have no reaction to amoxicillin, you may safely give any of the beta-lactam antibiotics. Again, this is well documented. The last slide, I think. Yes. So what do we have for take-homes after all of this? Number one, more than 95% of the patients labeled as penicillin allergic tolerate beta-lactams. The cross-reactivity for cephalosporins is 3%. So 97% tolerate cephalosporins. 99% of patients with a penicillin allergy tolerate carbapenems, and 100% tolerate aztreonam, with the exception of someone who had a reaction to ceftazidime. The 10-year penicillin allergy rule, at 10 years, 80% of patients lose skin test positivity, which is the surrogate marker for IgE immediate reaction anaphylaxis. So they can safely give it, again, if they're in that low risk category. The important thing is you need to take an accurate and a detailed penicillin allergy history of the symptoms, of the timing of the reaction, how long ago was it, greater than 10 years, what was the treatment, and did you take any of the similar beta-lactams without a problem. Risk assessment, as a result of your accurate history, you can make a risk assessment and put them into low risk category for allergic reaction, moderate risk, or high risk. And the management for low risk patients would be the amoxicillin challenge, which we went through. For moderate, you may want to do the amoxicillin challenge or do penicillin skin testing in the hospital. And if they're high, you would want to refer them to the allergist and the immunologist. So that's it in a nutshell. And if you have any questions, I'd be really pleased to answer them. Thank you very, very much.
This is Dr. V. Thank you, Dr. Allen. That was very good.
From Jeff, is there a specific certification needed to perform skin testing? Jeff, what they do is there is a I'm not sure if there's a standardized national protocol. What I would do is check with an allergist, an immunologist, and generally they would be the ones to educate your pharmacists or whoever are going to be doing the penicillin skin testing. And they can review that, and they could, document the certification if you would, and you probably would want to do that on an annual basis because you'll want to know the appropriate, it's pinpricking, it's subcutaneous, so that you want to make sure you're doing that properly and reading them properly. You also want to make sure that you have a anaphylaxis kit available should the person have anaphylaxis with the skin testing. Any other questions? Good question, Jeff. Is that it, Jackie?
I
It
think
sounds,
that's it.
yes, thank you.
Great. Thank you, everyone. Have a great day.
Thank you.
Bye now. Thanks, Jackie.